So we've recognized sepsis, and now it's finally time to treat it. And this brings us to the golden hour. So this graphic may already be familiar to you. It's from the latest surviving sepsis guidelines that were updated 5 years ago now in 2020. As you can see at the very top, systematic screening for sepsis in children is suggested, just like we talked about. And this is followed by time frame suggestions based on the suspicion of either sepsis or septic shock. So in kids with shock, the whole bundle that we'll go through must be commenced within 1 hour of recognition, which is why it's known as the golden hour. But to do this, we have to know how one differentiates sepsis from septic shock, right? So this is a quick reminder on the basic pathophysiology of shock. So DO2 refers to global oxygen delivery. This is governed by cardiac output and oxygen saturation, so I'll focus here on cardiac output. Cardiac output is governed by stroke volume and is dependent on preload, contractility, and afterload. So in kids, the ability to improve contractility in response to catecholamines, be they endogenous or exogenous, is limited because of insufficient muscle mass as well as stiffer myocardium when compared with adults. Hence, in kids, cardiac output is more dependent on heart rate than on the stroke volume. And this is quite important. So when kids go into shock, normally the first thing you'll notice is tachycardia. At this point, since blood pressure is maintained, it's known as compensated shock. However, as shock progresses and compensatory mechanisms fail, blood pressure drops, and finally, irreversible end organ damage may occur. So this graphs the relationship between delivery of oxygen, which is DO2, and consumption of oxygen, which is VO2. On the left side of the chart is a shock state. So when DO2 drops to a certain level, cells begin to produce lactate via anaerobic metabolism because there's not enough oxygen. And the whole point here is that we want to match oxygen delivery to demand and not reach that critical DO2 level where shock ensues. And we definitely don't want to reach irreversible end-stage shock. Okay, so on to the methods of initial resuscitation in the golden era. Step 1 is pretty straightforward, is to obtain vascular access. However, it's important to note here, if a child is poorly perfused and in shock, it might be extremely difficult to obtain IV access, in which case no time should be wasted and intraosseous access should be obtained instead and as soon as possible. So that one's simple. Step 2 is also easy to understand. So it's to collect a blood culture. It's best if this specimen can be obtained before antibiotic administration because we want to maximize microbiological yield. The blood culture might be the only source of information identifying bacterial antibiotic susceptibility. So it's important that one makes all reasonable efforts to collect blood cultures before antibiotics. However, given the impact of delayed antibiotic therapy on patient outcomes, it should only be prioritized if it would not delay antibiotic administration, okay? So if it's hard to take one, just give the antibiotics first. Step 2 also includes thinking about possible sources of infection apart from just the blood and collecting appropriate specimens, be it, for example, urine culture or an MPA. So step 3 is to start empiric broad spectrum antibiotics. So for this, the questions are when to start them and what to start. So if shock is present, as mentioned, the golden hour counts, and we want antibiotics to be given within the first hour. This is a wonderful diagrammatic illustration of how time-sensitive pediatric septic shock is. So it's taken from a retrospective observational study published in Critical Care Medicine around 10 years ago, and it was performed in an American PICU. Survivors are represented by the white bars and non-survivors by the black bars. And it shows that kids who experience antibiotic delays of more than 3 hours had almost a 4-fold risk of mortality in the PICU. And this was also later replicated by other studies that have shown that each additional hour of persistent shock is associated with more than a 2-fold increase in odds of mortality. And similar to adult sepsis trials, it shows that early administration of antibiotics were the single most important factor in reducing mortality. So it's incredibly important that one gives antibiotics as soon as one suspects possible sepsis. However, though, to avoid hazards of unnecessary antibiotic exposure and because mortality risk doesn't appear to increase significantly until after 3 hours, it's reasonable if the kid doesn't present in shock to first conduct an expedited diagnostic examination to confirm sepsis first. Okay, so next question is what antibiotic? So broad spectrum therapy is recommended for initial empiric therapy to increase likelihood that it's effective against the causative pathogens. So gram-neg bacteria is the most common cause of sepsis in kids, and up to around 60% of those with bacteremia. Though, of course, the relative prevalence of these pathogens can vary by age and location, for example, community versus hospital and other patient factors. However, generally speaking, a third-generation cephalosporin may be sufficient for a kid presenting with community-acquired sepsis. If you have an immunocompromised kid or hospital-acquired sepsis, then it's recommended to include anti-pseudomonal coverage. It's also important to note that, of course, there are many other specific conditions that may put patients at risk for atypical or resistant pathogens and require specific empiric regimens, and local epidemiology is also important to consider. So that should all be taken into account when considering what antibiotic to give. Step 4 is to measure lactate. So what is lactate? It's a byproduct of anaerobic metabolism when one goes into a shock state. Therefore, it can be a surrogate trend marker for adequacy of resuscitation. This box plot diagram is taken from a Korean study of kids with septic shock, showing the blood lactate levels in the survivor and non-survivor groups. So the survivors here are marked in white, and the non-survivors are marked in gray. Lactate levels were taken every 6 hours after presentation, and it's really obvious here. You can see that serolactate levels were significantly higher in non-survivors and as compared to survivors. So what do we do at the Prince of Wales? Well, concurrently with step 4, we do our other initial investigations as well. So a blood gas allows for a rapid acid-base assessment. It gives us an idea of respiratory status, as well as any major electrolyte disturbance. And of course, it also gives our lactate. So we do it in our POCT machine, and it comes back pretty much instantly. So on the right, I've put an example blood gas here of the worst I've ever seen. Like, it's crazy. The pH is only 6.3. And this is in a kid with fulminant septic shock. But incredibly, this patient later survived after really aggressive therapy. So other initial investigations we do at the same time as this blood gas are dextrosix. It's a quick investigation to determine glucose status. Sepsis can present with either hyper or hypoglycemia in kids, which is important because they can easily be remedied. Ionized calcium is often deranged in septic patients as well, and it's an important electrolyte governing our cells and helps with cardiac contractility. So we want to make sure that it's normal. And a chest X-ray is also a useful initial screen for a source of infection, and of course to assess cardiorespiratory status. And at this point in time, it's also important to mention that depending on available expertise and resources, initial investigations might also include a non-invasive hemodynamic assessment, like a quick echocardiogram or hooking up a non-invasive cardiac output monitor if these resources are available to you. Okay, so the meat of the talk is actually here. Step 5 is quite a controversial area. So what fluid should we give? How much fluid should we give? And also, how fast should we give it? So let's tackle what fluid to give first. So bottom line here is we're not even going to consider colloids, but essentially they're not better than crystalloids. They're a lot more expensive. They come with more risk, including allergy, bloodborne infection. So crystalloids are the way to go, and amongst them, balanced solutions are preferred over unbalanced solutions. So why is this, and what does balance mean? Well, here's a list of available crystalloids worldwide as compared to human plasma, which is on the left. And you can see here not all crystalloids are equal. So normal saline came first, and it's a complete misnomer because it is not normal in any way. Okay, it contains only two things, sodium and chloride, in incredibly superphysiological concentrations. So balanced was referred to as balanced crystalloids because the goal was that they were to be more physiologic with a fluid composition closer to human plasma. So you can see the balanced crystalloids, all the ones on the right-hand side, they contain less sodium, less chloride, and also some additional electrolytes. Here I've also sourced prices for each of the available crystalloids in the hospital authority. So you can see that normal saline wins out as being cheapest by far. However, normal saline has been steadily gaining a poor reputation. because of its associations with hyperchloremic acidosis. So more and more evidence has implicated normal saline as being associated with adverse kidney outcomes, such as increased risk of acute kidney injury, higher rates of renal replacement therapy, coagulopathy, as well as longer duration of vasoactive infusions, and of course, worst of all, poor survival. However, it's important to make this exception that NS should be considered if the patient already has hyponatremia or if there are concerns about raised ICP. Okay, so here, this diagram on the right, you can see it depicts increasing mortality when chloride levels are increased. So no good. This table illustrates 4 trials in critically ill adults comparing sodium chloride and balanced solutions. So the first 2 were pilot studies, and you can see the 2 on the bottom contain thousands of patients, and they were the larger trials. And you can see that they're all skewed towards balanced solutions having an edge over NS in terms of mortality on this forest plot diagram on the left. In the last 2 years, 2 more big adult RCTs were performed as well. So the balanced solution intensive care study, which is named BASICS, this one enrolled over 10,000 patients and compared the effect of normal saline or plasma-lite on 90-day survival in ICU patients. And they found that there was no significant difference in mortality between the 2 groups. However, in a subgroup analysis of septic patients, so those who had sepsis, those who received plasma-lite had a higher probability of 90-day survival compared to those who received sodium chloride. So they seem to work in our sepsis population. Another trial published in 2022, however, the PLUS trial, saw no difference in AKI on 90-day mortality between plasma-lite and NS groups. So basically, the evidence in the adult literature isn't that consistent. What about data in pediatric literature? So this is a matched retrospective cohort study in 2017 comparing the use of lactate ringers versus no lactate ringers, and encompassed over 12,000 patients with severe sepsis at more than 300 US hospitals. And they also found no difference in mortality. And in fact, they even found that there was a longer hospital length of stay in the lactate ringers group. However, this contrasted with a bigger retrospective data analysis of 37,000 patients over several children's hospitals in the US. So this database analysis showed that there was a lower mortality with the use of balanced crystalloids versus sodium chloride, as well as lower rates of AKI and days requiring vasoactive infusion. But they saw no difference in need for renal replacement therapy or PICU length of stay. So in 2018, and a year later, this is another retrospective data analysis, this time looking at the association between hyperchloremia and septic shock. And this showed that hyperchloremia in the first 7 days of septic shock was associated with increased mortality and multi-organ dysfunction syndrome. But as mentioned, this data was all observational. So finally, in 2023, we were gifted with the first RCT in pediatrics that examined plasma-lite versus normal saline as bolus fluid in pediatric septic shock. So in this study, 700 patients were enrolled across 4 pediatric EDs or PICUs in India, and they found that plasma-lite was associated with less AKI and lower rates of RRT. However, there was no difference in other important outcomes, such as ICU mortality, time to shock resolution, organ dysfunction scores, ventilator-free days, and inotrope-free days, ICU-free days. So basically, the data, there's some data, but it's not very strong, and this was the first RCT that was done. Luckily for us, there's actually another large pediatric trial that's currently undergoing. So it's the PROMPT bolus study, also known as the pragmatic pediatric trial of balanced versus normal saline fluid in sepsis. So this is an international open-label interventional trial, which is conducted across the US, Canada, Australia, and New Zealand. And actually, I was fortunate enough to take part in this study during my time working at the Royal Children's Hospital last year. So it examines balanced crystalloids versus normal saline for initial resuscitation in pediatric patients with septic shock, with the primary outcome being any major adverse kidney events within the first 30 days. So it's a composite of death, renal replacement therapy, as well as persistent kidney dysfunction. The aim of this study is to enroll 8,800 participants. So hopefully we'll get some results from this in another few years. So I hope that wasn't too confusing. So what does it all mean? So in essence, in both pediatric and adult studies, it seems that normal saline is associated with more adverse kidney outcomes compared to balanced solutions, but the evidence is not of high quality, and effects on mortality still remain uncertain and controversial, so the pendulum continues to swing. Thus, to date, there's no strong evidence for a recommendation for either. However, the Surviving Sepsis Campaign guidelines advocate for balanced solutions, given the very strong biological plausibility for the adverse effects of sodium chloride and hyperchloremia when compared to balanced solutions, which probably outweigh the undesirable consequences of balanced crystalloids like cost. Okay, so next question is how much fluid? So this is also a big one. The official Surviving Sepsis Campaign guideline recommendations are that if a PICU is available, to give 40 to 60 mils per kilo in the first hour and 10 to 20 mil per kilo aliquots. And if no PICU is available, to administer only in the presence of hypotension. So this calls for us to revisit some basic physiology principles and Jacques again. So our goal with fluid therapy, of course, is to improve preload, which can increase intravascular volume and therefore cardiac output, and therefore improving oxygen delivery. So keeping in mind that our ultimate goal is to match oxygen delivery with demand. And in revisiting the concept of how much fluid is appropriate, of course, we have to remember the Frank-Starling principle. So the heart has an intrinsic ability to adapt to different volumes of blood. The primary objective of fluid therapy is to increase preload, as mentioned. And if the heart is on the steep part of the Frank-Starling relationship, then an increased preload is expected to cause a rise in cardiac output, see big purple triangle. So this would be known as being preload or fluid responsive. However, after preload has been optimized, further fluid boluses would no longer lead to a significant increase in stroke volume, as demonstrated on the flat part of the curve, enter small purple triangle. And so it wouldn't help with increasing cardiac output. So if this point is reached, it would be wise to stop pouring further fluid in to avoid the effects of fluid overload. And when this point is reached, it's called being fluid refractory. In sepsis, preload can be reduced by two distinct mechanisms. So intravascular volume depletion, which can be caused by either genuine hypovolemia, for example, if the patient hasn't been eating well before coming in, or has a gastrointestinal infection and has diarrheal losses, etc. Or it could be via capillary leak, in which case, in these instances, fluid therapy would certainly benefit through intravascular depletion. Venodilation in sepsis, on the other hand, leads to sequestration of blood in the venous compartment, so in which case vasopressor therapy rather than fluid therapy would be the most beneficial in remedying this. So aggressive fluid resuscitation has been one of the cornerstones of supportive sepsis therapy for the last few decades. And this is a pivotal study done by Carcillo in 1991. It was an observational cohort study investigating the association of fluid administration and mortality in kids with septic shock. So it had around 30 subjects, and they're categorized by administered volumes of fluid bolus therapy in the first hour of septic shock. So either less than 20 mils per kilo, 20 to 40 mils per kilo, or more than 40 mils per kilo. And the study showed that those who received more than 40 mils per kilo had way better survival compared to those who received less than 20 mils per kilo, as you can see on the diagram on the right. Survivors are represented by white boxes and non-survivors by black boxes. So group 3 refers to the kids who received more than 40 mils per kilo. And in fact, the mean volume received by group 3 was really, really large. It was 70 mils per kilo of fluid in the first hour. In 2001, so 10 years later, a landmark study in adult land by Rivers showed the benefit of a time-dependent hemodynamic optimization of oxygen delivery using continuous monitoring of pre-specified physiologic targets. So in this case, it was CVP, MAP, and central venous oxygen saturation. So these are all parameters reflecting cardiac output. And it involved the use of early and aggressive fluid resuscitation in septic adults. So these adults received up to 5 liters of fluid in the first 6 hours, and an average of a whopping 13 liters of fluid overall. So that's 200 mils per kilo. If we consider a standard adult to be 60 to 70 kilos in weight. And in this study, there was a very dramatically, significantly lower mortality achieved with an absolute mortality benefit, as you can see here, of 16%. So because of this dramatic mortality benefit, and it was the first major effort to protocolize sepsis treatment, this ushered in a new era of time-sensitive bundled sepsis care. And this kind of care was incorporated into the first iterations of surviving sepsis campaign guidelines at the time. So simple, right? More fluid is better, right? Well, actually, subsequent studies were unable to reproduce the benefits seen in the RIVER trial. So around a decade after publication, there were 3 large international multi-center trials which further evaluated the goals in the RIVER trial, which championed liberal fluid resuscitation. So they were done in Australia, the US, and UK, and actually Hong Kong also took part in one of these. So they included aggressive fluid resuscitation of 1 liter in the first hour, and like the RIVER trial, higher volumes of fluid in the first 6 hours in the intervention arm compared with usual care. However, in all 3 trials, unlike the dramatic mortality reduction seen in the original trial, there was no difference in 90-day mortality. And then 10 years later, in 2011, in Pediatrics, the FEAST trial was published. So FEAST stands for Fluid as Supportive Therapy, and it was the first RCT in the world to provide robust evidence that fluid boluses might cause harm. So it enrolled 3,000 kids across several African countries with severe febrile illness and shock. And the kids either received 20 mils per kilo of fluid in the form of albumin or normal saline versus no bolus. And it found that there was a higher risk of death at 48 hours in the group that received a bolus compared to no bolus. And on further subgroup analysis, they were unable to identify any subgroups in which fluid resuscitation was beneficial. It's very important to note here, though, that in the FEAST trial, in these African healthcare infrastructure, there was no ICU admissions. There was no use of mechanical ventilation, no inotropes, vasopressors, or availability of renal replacement therapy. So at the time of publication, the FEAST trial generated a lot of controversy. It led many clinicians to question whether these trial findings were applicable in settings with an ICU. For example, 80% of the kids in FEAST had respiratory distress, which obviously makes fluid loading problematic, right, in the absence of rescue mechanical ventilation. However, they did a comprehensive reanalysis of the trial data later, and it highlighted that the main reason for excess deaths with boluses actually wasn't fluid overload. It was cardiovascular collapse. So it means there are a lot more factors at play which led to the increased mortality in FEAST. But it was very pivotal because it led to great anxiety over aggressive fluid resuscitation as one of the cornerstones of modern septic shock management, and to some very important questions. So, does fluid bolus resuscitation in patients with severe sepsis actually increase vital organ flow and cardiac output? And if it does, what is the magnitude of its effect? And how long does the effect last? Finally, what is the physiological price one has to pay to achieve this effect? So I won't be able to answer all these questions today, but there are some things to contemplate and keep in mind as we continue to ponder how much fluid to give. Okay? So this diagram demonstrates some of the effects of fluid bolus therapy in septic shock. So beneficial effects are highlighted in blue. It can improve cardiac output and tissue oxygen delivery, okay, which is what the basis of fluid resuscitation and sepsis is on. However, look at all of the red boxes which signify bad effects. So it can lead to tissue congestion in all your organs, including the brain, lung, liver, kidneys. It can worsen microcirculatory dysfunction, and it can cause human dilution or coagulopathy as well. So these various adverse consequences of fluid overload and the results of the FEAST trial led to increasing research on whether maybe pouring in so much fluid isn't a good idea. Like, is a fluid sparing strategy maybe of greater benefit in our sepsis patients? This study in Alberta in 2015 was a retrospective database analysis of around 80 kids with pediatric sepsis, and associations were compared between those who received more than 20 ml per kilo in fluid boluses versus less than 20 ml per kilo in the first 2 hours of presentation. And you can see that those who received more fluid had a longer PICU length of stay, and also a longer number of ventilator days, though the effect sizes were small. However, mortality was low in this study, so there wasn't any meaningful comparison that could be performed between the groups. This was a prospective observational study performed in Suzhou in China. So it enrolled around 200 kids from a PICU with severe sepsis, and it defined early fluid overload as 5% or more of fluid accumulation occurring in the first 24 hours of PICU admission. And subsequent daily fluid accumulation was recorded over the course of their PICU stays. So they noted that first, fluid overload is very common in septic shock patients, up to 20%, and this probably comes as no surprise to anyone who's managed these kinds of kids. However, higher mortality is also seen with early fluid overload in the first 24 hours, as well as daily accumulation of fluid overload. Significantly, the presence of early fluid overload was also able to predict mortality with a reasonable sensitivity and specificity. A systematic review and meta-analysis, specifically looking at the association between fluid overload or mortality and sepsis, was published in the BMJ in 2023, so just 2 years ago. It included 9 observational studies encompassing more than 2,000 kids with sepsis. And it showed quite definitively that kids with fluid overload of 10% or more in the first 72 hours had higher mortality with an odds ratio of 5. They also revealed higher odds for needing mechanical ventilation and a longer ICU length of stay. So finally, another study to give you food for thought and how much fluid is appropriate. So this one was published in 2018 by our Australian counterparts in the ED at Royal Children's Hospital. It enrolled around 40 kids with suspected sepsis who were treated with fluid bolus therapy of up to 20 mL per kilo of crystalloid. And their goal was to monitor the effects of fluid bolus therapy on the cardiac index. So pre and post intervention, they got a cardiologist to do a transthoracic echo and monitor the cardiac index. And they found that fluid responsiveness, which was defined by an increase in the cardiac index of more than 10% at 5 minutes, was quite variable. It was only observed in around 60% of kids, and there is no difference in the change with use of 10 ml per kilo or 20 ml per kilo groups. And if you look at this diagram, upon rechecking cardiac index at 1 hour, this increase wasn't sustained, and effects actually dissipated by 1 hour to an even lower baseline than pre-bolus. So obviously an observational study like this would be limited by confounding factors, but they actually do reflect reality in clinical practice and suggest there's a long way to go for us in understanding physiological effects of fluid bolus therapy. Anyway, so by now I hope that you've digested the take home from this section, which is that contrary to previous decades of research, new research has shown that giving fluid, though being an extremely important part of supportive management in sepsis, can be harmful. We have to be really careful in our titration because too much fluid is bad. So the key takeaways are that instead of 20 ml or larger aliquots, as traditionally advocated, we've moved toward giving smaller boluses. So Surviving Sepsis now recommends 10 to 20 ml per kilo. And frequent assessment is absolutely paramount to determine if our patient remains preload responsive or not. And given increasing evidence of the potential harms of fluid overload, the world is trending toward more fluid-sparing resuscitation. So the final question was how fast to give fluid. So the Surviving Sepsis campaign recommendation is for it to be given over 5 to 20 minutes. 2 RCTs in India reported results of their studies comparing fast, which was giving the bolus over less than 15 minutes, versus slow, which meant giving the bolus over 15 minutes. Administration of fluids in kids with septic shock, and they found that there was no mortality difference, nicely illustrated in this forest plot. Okay, so we're coming toward the end of the golden hour. The 6th and final step is to start vasoactives if shock persists. So several questions exist here. What vasoactive agent should we pick? When exactly should we start it? And how do we give it? So going through the exact mechanisms of action of each of these won't be my focus today, but I'd like you to pay attention to this line, saying dopamine is only to be used in a zombie apocalypse. Well, I definitely hope that we don't get a zombie apocalypse anytime soon. But I recall that when I first started practicing, dopamine was a solution for everything, in every instance of shock or hypotension. So why is it no longer popular? Essentially, a bunch of trials, once again pioneered in adult land, show that norepinephrine, so noradrenaline, is superior to dopamine in terms of both mortality as well as shock resolution. Norepi is the first-line agent for septic shock in adults, and dopamine is out of favor. If we look at pediatric data, 2 RCTs were published in Pediatric Critical Care Medicine around 10 years ago now, and they had a combined total of 160 kids with septic shock, and showed that there was much faster resolution of shock. So adrenaline was 3 times more likely to achieve resolution of shock within the first hour of resuscitation when compared to dopamine. So that's a very significant time difference. And similar trends were seen up until 6 hours of resuscitation. Early resolution was also associated with improved organ function. And most importantly, there was also improved survival. So this is exemplified on this Kaplan-Meier curve on the right-hand side. So improved survival with epinephrine, so adrenaline, when compared with dopamine. This recommendation is taken from Surviving Sepsis once again. So essentially, both adrenaline or noradrenaline are suitable first-choice vasoactive agents, but depend on underlying patient physiology. So typically, we can categorize patients at the bedside according to clinical phenotype. Warm shock is characterized by high cardiac output and low systemic vascular resistance, which manifests as a very wide pulse pressure and low diastolic blood pressure. Clinically, the patient would appear warm with flash capillary refill and bounding pulses. So in cold shock, it's characterized by the opposite, a low cardiac output and high systemic vascular resistance, which leads to a narrow pulse pressure, cold extremities, prolonged capillary refill, and weak peripheral pulses. However, despite this, it must be emphasized that clinical parameters are not the most reliable. So they're definitely not 100%. And if you're able to perform a non-invasive hemodynamic assessment, just as with echo or cardiac output monitors, this would be more accurate than bedside markers, and this is also advocated for by Surviving Sepsis. Okay, so next question is when to start. Well, pretty straightforward. Start when shock persists after initial fluid resuscitation and if the patient is no longer preload responsive, because further volume at that point, as we demonstrated, won't improve cardiac output and in fact could cause more harm than good. So vasoactive agent should be the next step in order to optimize cardiac output and improve oxygen delivery. This RCT in India enrolled around 50 patients from the ED and PICU with septic shock, and they'd all received antibiotics already in the golden 1 hour of shock recognition, as well as fluids. And they were randomized to receiving noradrenaline after 30 ml per kilo of fluids or after the standard of care as recommended by Surviving Sepsis, which is 40 to 60 ml per kilo. And they saw that in the noradrenaline group, there is a trend toward a less positive fluid balance, shorter PICU length of stay, as well as more ventilator-free days. However, there was no difference in shock resolution or in mortality. So similar concepts have also been evaluated in adult land. So this trial evaluated the early use of norepinephrine, so noradrenaline, in septic shock. And it was a high-quality adult randomized controlled trial that took 300 adults with septic shock. So the intervention arm was low-dose noradrenaline versus standard of care, which is similar to the Indian trial we just looked at. So those in the intervention group with early starting of low-dose noradrenaline saw faster shock resolution and much lower incidence of acute pulmonary edema. Surprise, surprise. However, once again, there was no mortality difference demonstrated. Finally, last year, so this one is really new, there was a pilot trial performed in Australia across 4 pediatric EDs. Same concepts, but this time starting adrenaline after 20 ml per kilo of fluids only versus standard care. And in this group, obviously, in the intervention group, there were less total fluid volumes received, but in this small trial, there was no difference seen in organ dysfunction-free days or PICU length of stay. Also, the overall acuity in this cohort was low, and there were no mortalities recorded because most of the patients did well without further fluid or inotropes. So they were unable to comment on this study on severity outcomes. But it was a pilot study, so they plan to enroll more patients in a bigger trial. So to conclude on when to start vasoactives. So basically, I've just added here that the trend in recent studies have been investigation of a more fluid-sparing strategy with earlier vasoactive initiation. So maybe even after only 20 mils per kilo of fluid. So maybe even prior to fluid refractoriness setting in. And a final question in this part is how to give vasoactive agents. So this is something we frequently encounter actually in our daily practice as someone with a PICU. There's a lot of hesitance amongst acute pediatric care providers in starting vasoactive agents without a central line. So truthfully, local adverse events with peripheral vasoactives have a very low rate of occurrence, and a systematic review published just last year showed that there was no relationship between concentration of agents used and rates of local adverse events, hard as it is to believe. This is a closer look, so it included 16,000 patients across 13 studies. In the majority of these, either adrenaline or noradrenaline were used. And the forest plot shows the incidence rate of local adverse events associated with infusion of vasoactive through both peripheral venous catheters or IO. And pulled together, the incidence rate was really low. It was only 2%. So given this data, though derived from adults, the benefits of early vasoactives via peripheral line would certainly outweigh the potential risks, and it's also something that we do in our own practice at Prince of Wales. We just give inotropes via peripheral line prior to the placement of a central line. Here I've also provided some example dilutions of adrenaline and noradrenaline just for your reference if you come from somewhere that's unfamiliar with these vasoactives. So these dilutions are referenced from a pediatric clinical guideline at the Evelina. It's a large and internationally renowned children's hospital in London. So without further ado, I've created some summary slides just to wrap up the gist of what has been covered today. So our children finally got updated definitions last year via the Phoenix score, and sepsis has been redefined as a life-threatening organ dysfunction due to a dysregulated host response to infection. So this is finally in line with the adult definitions and also reflects what we see in our daily practice. Sepsis and septic shock are a major cause of morbidity and mortality in peds, and patients at the most extremes of age are most severely affected. The majority of pediatric deaths are in the under 5 population. Early recognition and treatment by implementation of systematic screening and sepsis bundles are associated with better outcomes. Improving sepsis education and awareness also doesn't mean it's only amongst health professionals. It extends to policymakers, health administrators, as well as the general population. And if we quickly recap the 6 vital steps in the golden hour, they're as follows. So we want to obtain vascular access as soon as possible and to not dilly-dally with peripheral IV if they're shocked and it looks difficult. We should go straight to an IO. Next step, take a blood culture, but if it's difficult, we shouldn't delay antibiotics because antibiotics are the single most important time-sensitive treatment that we can offer to our patient that can improve survival. Number 3, start empiric broad-spectrum antibiotics within 1 hour if the patient is shocked, and remember to consider specific conditions as well as local epidemiology. Number 4 is to do initial investigations, including your gas and your lactate, which has significant prognostic value and is also very useful for monitoring efficacy of hemodynamic resuscitation. Next step, push fluids quickly, choosing a balanced crystalloid if that's available to you, keeping in mind that frequent reassessment for a satisfactory hemodynamic response is really important. Stop if the patient isn't fluid responsive or if signs of fluid overload develop, because it's associated with mortality and adverse kidney outcomes. So nowadays we're moving towards a more fluid-sparing strategy. And finally, with vasoactives, goodbye to dopamine. Start either adrenaline or noradrenaline early, depending on the patient's underlying physiology. And a very important footnote is please give them by a peripheral route. If they need vasoactives, don't hesitate, and it's very, very safe. So there's a lot of other exciting domains in pediatric sepsis I haven't managed to go through today, but it would be beyond the scope of the initial golden hour. But I've listed the topics here for you just in case you're interested. And finally, I'd like to share a case of sepsis with y'all, which hopefully can help bring home the main points I've shared today in the golden hour. So last month, we had a 21-month-old girl come in. So she had good past health, and she presented with fever for 4 days with cough and runny nose. So seemingly just a viral infection, innocuous. She attended a general practitioner on day 1 and was treated with symptomatic medications. However, she then reattended on day 4 because caregivers noticed that she had shortness of breath, she had a very poor appetite, and appeared to be lethargic. So the GP referred this kid immediately to a private hospital ED. On arrival at the private hospital ED, the GCS was full, the patient was severely tachycardic, though blood pressure was normal. So what does that tell you? Sounds like compensated shock, yeah? The respiratory rate was okay, there was no airway obstruction, and some craps were heard over the chest. At the time, the patient, though, was desaturated, but responded well to 6 liters of face mask oxygen, and the tummy was slightly distended. So this is not the exact patient's x-ray, but it's very, very similar. So you can see that there's evidence of pneumonia as well as a small pleural effusion. So after this, without further ado, the private hospital ED physician transferred the patient to our center via ambulance. So upon admission, the ED colleagues at Prince of Wales immediately admitted this kid to their R room, and she was desaturated still. So she was already on 6 liters of oxygen, but SATs were only 90 to 91%. GCS at the time was still full, and the patient continued to be tachycardic. However, they had difficulty getting up blood pressure. So upon seeing this kid, they urgently consulted us, and we arrived within 5 minutes. So a quick assessment of the kid, she looked tired, but then developed sudden loss of consciousness and became apneic and cyanotic. The heart rate continued to show 80 per minute on the monitor, but there was no pulse. So basically she arrested on arrival. Our team gave CPR, intubated the patient, put in 2 IOs and pushed fluid. They searched for possibility of reversible causes, so 6 H's, 5 T's, and there was severe and refractory hypoglycemia. They gave a lot of dextrose boluses, but it failed to bring up the dextrose 6 to a sustained normal value. And so in the end, this patient died. So we gave CPR for around an hour and eventually took an intracardiac tap for some post-mortem bloods to be sent. So may she rest in peace. Of course, this family was very affected by such a sudden death of their beloved child. Eventually, the intracardiac tap blood culture came back to isolate strep pneumonia. So as mentioned in epidemiology, this is a common pathogen that's implicated in sepsis. So I hope this case kind of brings home how important sepsis is. So obviously, there was delayed recognition in this case, or there was recognition without any initial resuscitation steps. So none of them were done. They didn't put in IV, they didn't start antibiotics, or even give fluid. So hopefully this, bring home the point to you all about the importance of the golden hour. Who knows if earlier antibiotics might have saved this patient, but clearly she was compensating so hard that she just suddenly arrested upon arrival, and by then it was too late. So thank you very much, everyone, for your attention, if you've managed to stay with me up till now, and I welcome any questions.
好，咁咧就好多謝 Anna， 好詳細嘅一個discussion。before 啲人問問題，我想問一樣嘢啦。Rory regulation 咧，而家我都開始教啲 medical student。咁喺美國咧，我都聽到其實一年都救翻好多人，即係自從呢個 Rory regulation 之後。譬如喺香港嘅 AED，你覺得佢哋會唔會 即係採用呢個 approach 咧，或者即係都 adopt 入邊嗰啲即係講嘅嘢咧？6點啦，頭先你嘅個 summary 都係 Rory Regulation outline 嗰啲嘢嚟嘅，係嘛？
係啊，好類似，即係 Rory's Regulation 咧就係有個 1 hour 嘅 sepsis bundle 啦。咁佢係每個 institution 咧可以整自己個 bundle。不過個 components 咧就係 recognition 再加佢會有啲 initial treatment within 1 hour 啦。咁就係 antibiotics 咯。咁佢就冇講 fluid 咁樣嘅。咁我覺得如果喺即係喺我哋嘅 ED implement， 就如果要 HAY 咁樣去推咧，就比較難咯，即係可能要 institution based 咁樣去推嘅。不過我覺得最緊要可能都係自己 PD 入邊做咗先咯。譬如如果睇翻你自己 PD department， 你有冇一個sepsis screening 或者有冇 sepsis bundle？ 咁可能係我哋自己度開始先。咁 for example， 如果我哋真係見到有 clinical benefit， 我哋又可以用，我哋見到啲 outcome 真係好咗喎，咁跟住再推去我哋嘅 ED colleagues 咯。即係 even though 咧，我哋見到前線去 manage 即係 golden hour 嘅嘢，其實都係 ED physicians 啦嚇。可能都要喺我哋自己度開始，我哋先推到俾其他。
不過我覺得即係其實而家係多咗好多 collaboration 嘅，即係無論PALS 啊。NLP 啊，你都有 involve 啊，咁其實我覺得就都唔使咁 cautious 嘅，都我諗即係你呢堂書我都會推介俾你聽下，即係希望我哋即係睇一睇，其實佢哋個 role 都好重要嘅，
好重要啊，係啊，即係我覺得有任何疑惑就establish access 啊，打咗 antibiotics 先咯，即係有時都好難，可能抽到個 blood culture 咪俾咗 antibiotics 先，因為 antibiotics are the most time sensitive thing that can improve outcomes. As you saw, like any delay by an hour can increase mortality by more than 2 times. And of course, if the patient presents to an ED where pediatric support is available, then you have a good relationship with them. Just let them know. As soon as you're worried, could this be sepsis? Just call us.
Rory 咧就佢媽咪就好醒嘅嚇，咁咧佢就講咗一個字俾個 family physician 聽話我小朋友有 mottling 啊咁其實又唔係好 recognize 到，咁即係而家我教書都教啲學生話，其實 mottling of skin 都好重要。第一，第二咧就喺 A&E 嗰度咧，就佢哋 miss 咗啲 results 嚇。我諗大家都記住呢樣嘢嚇。你抽咗 result 就 close loop 睇翻轉頭，即係啲 result 係乜嘢。咁不過 Rory 嘅死都係即係都有啲安慰就係。其實呢個 regulation 出咗之後咧，就每年都救翻好多人。係啊，
即係 I think it's quite amazing 咯。佢個 family 係真係用咗佢個 death 咁樣去 advocate 咯。
咁我想替下鄭俊輝醫生，我哋個老友嚇，咁問呢個問題，佢話 As many cases of sepsis are bacterial infection superimposing on viral respiratory infections, do you think that earlier prescription of antibiotic at the primary care level is appropriate, inappropriate patient might help to prevent progression to sepsis. Even without the bacteriological results.
係，好多謝鄭醫生嘅 question 啦。I absolutely think that earlier prescription could prevent progression to sepsis. Or how can we say it? So if there's any query that possible sepsis might be present, then earlier antibiotics would definitely help.
另外一個問題我想問咧，我哋籠統咁講就話即係 septic shock 啦，其實個 pathogen itself 會唔會都影響個 outcome 咧？即係我哋嘅 recognition 可能係譬如 gram negative 嘅 bacteria， 又或者即係其他呢排我哋就成日講啲 strep 啊，呢個你頭先講呢個 pneumococcus 啊咁樣，先前9月就可能都記得，都唔係細路仔嚟嘅，即係有一班人去買餸嘅，其實 strep 都即係令到好多人識嘅，一個死咗添。咁what kind of bacteria would it affect the outcome or natural cause of the septic shock?
I think your question is great, thank you. So definitely. So, for example, there are certain bacteria that are associated with certain clinical phenotypes. You mentioned strep. So, group A strep is notorious for possibly causing toxic shock syndrome, and that can lead to very fulminant, rapid progression of organ dysfunction and death if it's not stopped quickly. going back to Dang Yiseng's question, so when I was in Australia, I saw so many cases of group A strep that had to go on ECMO and so many cases of mortality. And it's weird because we saw that there were an increased number of gas cases in certain Western countries like the UK, Australia, for example, after COVID. And I kept waiting to see the same phenomenon in Hong Kong, but hasn't seemed to occur. So I feel like in part it might be because, actually we're pretty lax in antibiotic prescription at the primary care level. And I don't know if that might have contributed in part to the fewer gas or really severe fulminant sepsis that we see, incidents as a whole in Hong Kong. Yeah.
尹錦明醫生就有個 follow-up question 嘅，佢就 In view of the usefulness of early use of antibiotic, what is your comment on giving one dose intramuscular antibiotic at GP clinic before transfer? Also take into consideration that in Hong Kong, patient can reach AED in 20 to 30 minutes.
Thank you very much. I think this is the exact kind of question that I was hoping to get because I think absolutely this would help. So if we go back to the case that I shared, so the kid presented with 4 days of fever, cough, and runny nose, which sounds like it might have just been a viral infection at first, but we know that in sepsis a lot of the time it's a secondary bacterial infection. So the kid has a viral illness to precede it and then develops sepsis after on top. The presentation of that kid was fever, lethargy, and really poor appetite, right? So looked terrible, the patient was tachycardic, and clearly that should give red flags for sepsis. So if at the GP they were able to give one dose of an intramuscular antibiotic, it would definitely improve this kid's chances of survival, even if the A&E is kind of relatively close by. And also, not to throw shade on the management in the private hospital, but what the GP did was, in our case, is refer the kid to an A&E. And what did that A&E do? Nothing. The A&E was able to recognize that this patient was ill, but just sent the kid on to another A&E without treatment. Definitely, if antibiotics could have been given, or even some fluid, I think that might have improved this kid's chances of survival. It might not have changed the outcome, though, in this kid, but I'm sure it would help another kid who might be less shocked on presentation. Yeah.
我諗大家都 share 個 same sentiment as Rory's parents 啊，即係其實係好突然，同埋即係有時覺得好唔抵啊 ，strap 都死真係好唔抵嚇。咁所以我諗大家都值得留意嘅。
係啊，同埋我覺得喺呢啲情況，即係 sepsis 咧，佢 progress 得好快，即係我寧願 overtreat 少少。如果佢真係冇嘅，咪早啲停針，其實係好 reasonable 咯。因為個 outcome that we're talking about is death. Yeah, it's death.
咁我好希望如果仲有一條題目嚇，咁阿鄭醫生就問molecular diagnosis of respiratory specimen many a times yield multiple viral and bacterial pathogen with the same specimen. How to distinguish which is the true culprit, or merely some DNA or RNA remnant without true clinical significance? 好難啊！呢個真係有時做我諗每個 test 都有好多佢個limitation 啊 ，molecular 就其實好多嘢都放大好多。你點睇啊？
So in relation to sepsis, so I think it may be difficult, right? So it depends on the presentation and whether you think if this patient is septic, if the respiratory source is the most significant. Yeah, but I'm sorry, I don't have enough expertise in that area to know. But what I have looked at is that there's molecular diagnosis of blood specimens now, which are geared towards picking up bacteria or viruses, and they can come back in a few hours. So I feel like if we're able to employ these kinds of molecular diagnoses on blood specimens, that would certainly be able to speed up our sepsis recognition process and help narrow down our antibiotics, things like that.
其實鄭醫生嘅問題
Sorry, I know it's not entirely related to
Yeah, 但係我覺得鄭醫生呢個問題係好 relevant 嘅，即係其實講緊early diagnosis。我 show 翻呢張 slide，其實咧我哋真係希望咧 嗱，上醫治未病咧就有時都好難㗎啦嚇，咁但係都做下中醫啦嚇，中醫治肉病，其實咧 early recognition 真係非常非常非常重要。我估 Anna 今日呢個 talk 嘅目的咧，都係希望大家可以早啲 recognize 到，咁即係去到耳病咧入咗 PICU 或者係 A&E。點咧其實都係唔理想嚇，咁所以我都希望大家即係留意下呢樣嘢。咁呼應翻我開頭講Covid、SARS、empty chairs and empty table。咁我都希望大家即係而家好似天下太平咁，但係到有一日又好似 Covid 又好似 SARS 嗰時，其實我哋又識唔識點 respond 咧咁樣？咁我都希望即係到時都係大家變咗上醫啦嚇，上醫治未病咁樣。咁我諗今日個 theme 都好重要嚇。咁好啦，咁咧就都呢個 talk 其實 overrun 啦，但係唔緊要，有啲時間我攞咗啦，攞嚟播音樂。咁好多謝阿 Anna。咁台面有個紀念品我送俾你嘅嚇。呢個電話咗我送俾你，好多謝你。咁咧就我知道你用咗好多心機去 summarize 啲findings 啲 recent literature， 同埋呢個 take home message 都係對我哋大家都非常之有用。咁再次多謝你。咁咧鼓勵你再嚟講嚇。
唔係應該真係好多謝在場，即係 this educational platform for pediatricians and anyone who takes care of kids in Hong Kong is just amazingly educational。
好多謝 Anna， 多謝 Anna。咁希望你好快又會再嚟講第二個 topic，好嗎？